Um, all right. Good afternoon, everyone. I'm gonna give it just a minute because I think I see folks still rolling into the Zoom room here. Okay, I think we may have hit a critical mass. So welcome everyone. Craig, are you our AV? Uh,
I am. Should I just share the
okay.
screen?
Yeah, that'd be great. Okay, so welcome everyone. First of all, I'm so thrilled that so many of you are here, both work group members and the public, because we got this meeting. We scheduled it and got it on the books as soon as we had a full complement of work group members. So I'm just thrilled that we're there and we're able to begin this group. Today's meeting is really going to be an introductory meeting. We're gonna introduce ourselves to each other, go around the room and introduce ourselves. I'm gonna give an overview of the work group charges. We're going to talk about an extension of the request for the work group's work. And as we go through the charges together and the statute that created this work group, requires our report by December 1st, which is in less than 2 weeks now. So we're going to need an extension. We're going to need a little more time. We'll talk about that. We're going to go through a high-level overview of some initial data where I'm going to share some of the things that we're seeing for our fully insured commercial market. And then the HSCRC is going to talk about a little bit what they have at their disposal. And we'll take comments from the public as time allows. We're also going to talk about along the way the process for appointing the work group chair. We're going to follow up with that in writing, but the legislation specifically requires work group members to appoint a chair. So Debbie Rivkin and I are chairing today. We may not be your chairs forever. We'll send out after this a process about that. So, Debbie, I'm going to ask you if you wanted to say any words before we proceed to introductions.
No, hello everybody. I'm Debbie Rivkin, and the Director of Government Affairs for the HSCRC. And I think Marie covered everything today.
Great, thank you. Okay, so can we go to the next slide, please? Okay, so this is our rough agenda today. At this point, and I know Chair Beidel, who is the sponsor of the Senate legislation that created this work group, was driving. So I'm going to see if she is able to say a few words. Chair, are you there?
Marie,
Okay.
can you
Yes.
hear
Oh
me?
my goodness. Hi, Madam
Oh,
Chair. How are you doing?
on Ritchie Highway, so I'm going to be short. Thank you. Thanks for the opportunity. I just really want to thank you for organizing the work group, Marie, and I know that you'll do a really good job figuring this out. And I saw the documents that you sent, but I have to tell you, I have a lot of other information about denials that we'll have to talk about as we go along. But I know it's a real concern, particularly for our hospitals. So thank you for your work.
Great. Thanks so much, Madam Chair. And yes, we will share some data that is probably the tip of the iceberg of data that folks have. So yes, absolutely. Thank you. And Delegate Kerr, wanted to open it up to you.
Oh, thank you, Commissioner and Director Rifkin and Senator Beidel. The legislation, HB 995 and SB 776, that established this work group to study the rise in adverse decisions. So we're charged with analyzing insurance denials, prior authorization decisions, and reporting standards, and eventually making some policy decisions. So in Maryland, we have some insurers with denial rates far above the national average. Maryland's largest carrier, Care First, has a denial rate of about 17%, which is in line with national averages. However, United Healthcare has a 32% denial rate, making it a national outlier. And this resulted, according to Johns Hopkins, as the reason why the Hopkins healthcare system did not renew its contract with United Healthcare, citing aggressive claim denials, affecting roughly 60,000 patients. But after several years of work, the Maryland General Assembly passed some legislation last year, HB 820, which went into effect October 1st, and this requires insurers provide a clear rationale for denials, identify the decision makers who made the denials, streamline the appeal process. But still, in Maryland, we have no standard definition of what an adverse decision is. We lack a statewide reporting system, and we have no consistency among carriers regarding the appeals and grievance process. So the current situation results in delays in treatment, higher out-of-pocket costs, administrative burdens, increased overhead costs, cash flow problems for hospitals and providers. And what compounds the problem is that appeals are usually successful, but the appeal process is not standardized, and patients lack the knowledge and even how to engage in the appeal process. So in the General Assembly, we have a pretty good idea what the problem is, and today we're looking forward to hearing from stakeholders about solutions, and just want to thank all of you who've taken the time to join us today in this work.
Thank you so much, Delegate Kerr. Can we go to the next, maybe 2 slides ahead? Okay, great. I'm just going to go down our list and ask folks to introduce themselves and just say a quick word about your hopes for this work group. So I've already introduced myself, and I'll talk in a little bit more detail about the Maryland Insurance Administration's role in adverse decisions and denials a little bit later on. Debbie, did you want to say anything else here before I go to Dr. Lindsay?
No, please go to Dr. Lindsay. We've got a lot to cover, so I make sure we get through everybody.
Okay, Dr.
Thanks.
Lindsay.
Hi, good afternoon, and thank you, Marie and Debbie. I'm Gingy Lindsay. I'm Chief Medical Officer with the Maryland Department of Health. I'm working primarily with our Medicaid plan, our program. Hopes for this work group, I think at the end of the day, to ensure that our residents with Medicaid insurance can get the right care at the right time in the right place, the lofty triple or even add the quadruple aims and providers will also have a good experience with our plans as well. And thank you.
Great, thanks so much. So we have Nikki Mayuski listed as a member for the Maryland Healthcare Commission. I don't see Nikki on the list though. Okay, maybe we'll come back to the Healthcare Commission. Megan Priola.
Good afternoon. I'm Megan Priolo. I'm the Executive Director for CRISP, the Health Information Exchange, a health data utility serving Maryland. I'm looking forward to learning more about these important issues and understanding where CRISP can play a role to hopefully be of assistance in sharing data. Thank you.
Thanks so much, Megan. Kim Camerata.
Good afternoon, everyone. I'm Kim Camerata, the Director of the Attorney General's Health Education Advocacy Unit. We were actually initially tapped with assisting consumers with appeals when private carriers deny coverage of all or part of a claim, and we do that sort of as our daily work. So we're working with the consumers frontline on these issues and look forward to studying them more closely.
Great. Okay, next up, Patrick Carlson.
Good afternoon. afternoon, everyone. I'm Patrick Carlson. I'm the Vice President of Care Transformation and Finance at the Maryland Hospital Association, and I'm really grateful to be able to contribute to this work group. I think, as many of you know, the challenge of denials has really been a difficult one for our hospital members, and we've really seen significant increases in the number of denials really since 2013. And so I see a real opportunity with this work group to work in advancing solutions to enhance transparency and reporting on denials, and and to come up with some solutions to reduce problem denials that we're seeing. So thank you for the chance to participate. I look forward to this.
Great, thanks, Patrick. We do have Dr. Doug Jacobs here, who's the Executive Director of the Maryland Healthcare Commission. Dr. Jacobs, did you want to say a few words?
Hey, thank you so much, Commissioner Grant. Sure, really happy to be here, happy to be part of the discussion. Like Dr. Lindsay, just broadly making sure that folks are getting the right care, right time, right place. And happy to be here and listen to some of the data and figure out how we can chart a path forward together. So thank you.
Great, thank you. Zach?
Hi, good afternoon. I'm glad my middle name is listed on there. It makes me feel more formal on this. Zach Peters, I'm the head of state government affairs for the CVS Health Enterprise in Maryland and all of our affiliated entities. Greatly looking forward to the conversation and digging in with this work group. Thank you.
Great, thanks so much. Jai?
Hi, my name is Jai Sunarayan. I'm the Chief Executive Officer for Jai Medical Systems. I'm happy to be here with the work group and eager to understand what the hospitals are seeing in terms of adverse decisions and how Medicaid managed care plays a role in finding good solutions to the problem.
Great, thank you. Heather?
Hello, I'm Heather Little. I am with University of Maryland Medical System. I've been with the organization for 28 years. Before that, I was with GBMC for 7 years. Some of the things that you've already hit on definitely resonate. I oversee the clinical denials team for University of Maryland Medical System, and our initial denial rate is 20% of our revenue. And after a lot of man hours, and resources from lots of different internal and external sources, we're able to get that down to 3%, but that's a lot of work. So I'm looking forward to working with this group to see if we can make some change. Thank you.
Great, thanks so much. Tori?
Hey, good afternoon, everyone. I'm Tori Bayless. I'm the CEO for Luminous Health. I appreciate Delegate Kerr's summary at the outset, and also the leadership of Chair Beidel in Senate Finance and the work that went through HGO. I guess if I'd say what I'm hoping to get out of this, I'd like to get to more solutions versus just we continue to describe the problem. I think we do understand the complexity and difficulty and the financial strain that this all causes. I would like to get to a higher level of transparency and also reduce the variability in the numbers of rules and regulations and routes in which denials can occur. And I would hope that we focus not only denials of payment for services that have already been provided, but also denials and delays in authorizations for care and services. And while I appreciate some of the denials work comes up through and is adjudicated through MIA, the vast majority are not. They're run through the hospitals with enormous resources put to task to get a 17 or a 19% denial rate down to 4% or 3%. So when 75% of them are reversed or overturned, I think we should all be able to agree we've got a real big problem on the front end. So I'm hoping for some solutions, and I can provide a whole lot of data for our own health system, and also I have the opportunity to work with the Maryland Hospital Association and the American Hospital Association as well.
Great, thanks so much, Tori. Dr. Oriefo? Okay, Dr. Hader?
Hi, I'm Vicky Hayter, and I'm with Emerge Lifestyle Consulting, representing behavioral health provider in private practice. And what I like to get out of this is I see the patients directly, and I hear a lot about the impact that their denials are having on them, and even more recently, in particular around with United Healthcare and the effect that it's having on their healthcare health, the current health diseases and things that they currently have going on. So I'm representing the direct patient care and the impact it's having.
Great, thank you so much. Gaytain?
Good afternoon. My name is Gaitan Brunson. I'm a registered nurse and a director for medical review and appeals for Care First. I'm happy to be on the work group, and I appreciate you allowing me to be here to listen, learn, and understand and take back any information to our plan to assist our members and providers. Thank you.
Great, thank you so much. Dan?
Yeah, Commissioner Grant, Debbie, everybody else, thanks very much. Exciting to be here. Dan Martin, I'm the Chief Policy Officer at the Mental Health Association of Maryland. And then, my 15 years here, we have it's been really just seeing how denials, delays, and barriers to needed care really impact and create a significant burden on individuals and their families that are seeking care. And so, I looked ahead a little bit I looked ahead at the data that we're going to see in just a couple of minutes. And we'll see that mental health services are quite an outlier in a negative way in terms of adverse decisions. And so looking forward to working with this group to kind of come up with some solutions that can make sure that, again, folks in need of mental health care can access the services that they need. So thanks very much.
Great, thanks, Dan. Dr. Singh?
Hi, good afternoon, everyone. I'm Dr. J.D. Singh, internal medicine specialist, private practice in Prince George's County, Bowie, and Greenbelt area. So I'm here to, I think, voice the balance between as much as we want the abuse and the not so much fraud, but misuse and what can be avoided. To balance with what has been said in private practice, how it leads to more hospital use and ER use of the same things which we cannot get early authorization timely, and how it affects private practices to be able to help individual patients get better health at the most easier available point. So I'll be looking forward to contributing that.
Great, thank you so much. Dr. Zama?
Hello, good afternoon all. Thanks it's a pleasure joining this August group. And I want to associate myself with what Delegate Carr said and the other hospitals said, especially with United Healthcare Insurance. The amount of denials is really astronomical. And for somebody like me in private practice, I don't have the resources to fight it. Over 10 years, example of cases that have had denials from United include seeing patients in the ICU on life support, discussing withdrawing life support, switching them to hospice, and then they pass. We send the stuff to United. United says that, oh, there was no authorization, there is no indication for palliative medicine. That is just, I don't know what to say, right? I've gotten to the point where United patients used to follow me outpatient. At this point, I don't take United patients anymore because of this. The only thing is in the hospital, I cannot refuse not to see them when I'm consulted. But even then, doing something that actually saves money to United tells me that there was no indication for a palliative medicine consult. So I would really like for us to get down to the bottom of this to resolve this, because as I say, there are small physicians, independent physicians that don't have the resources to fight United or other insurances to decrease the non-reimbursements. Thank you.
Thank you. Thank you so much. Dr. York?
And thank you so much for the opportunity to participate in this work group. It's a huge importance, and it's a problem that, just as we all stated, is significant financially to the patients, and it's growing. And to go from high 20s, 30% denials down to 3, and we see this all across the country. I'm a past president of MedChi. I'm an orthopedic surgeon at Luminous, so I canceled my afternoon clinic to be with you all, and I certainly appreciate this opportunity. I just came back from the interim meeting of the AMA meeting, where I'm a delegate from, and this is a problem all across the country. And so MedChi has fought this and sought to get solutions for decades. On a federal level, we're working on it, and we really have to get granular, find something that has some teeth, and do something for our patients. Well, even this morning, I had a Priority Partners patient that couldn't see me. The patient was here, and they had worked for a long time to try to get the Priority Partners just visit authorization. It's not like a lot of money, but the patient had to be turned away, and I just felt bad. Thank you again.
Thank you so much, Dr. Georgina.
Yes, hi everyone. Good afternoon. My name is Georgina Baez, or Gina Baez, and I'm here representing Baltimore Medical System, a federally qualified health center, the biggest federally qualified health center in Maryland. I am the director of maternal and child health, so I'm here to learn, to collaborate, to advocate for the families that we serve, and every patient also in the state of Maryland. We know that in the US we have maternal and child outcomes that are not stellar, and it's going to take all of us collaborating and working together to improve our outcomes for maternal child health and for every other patient and specialty. Thank you for the invite.
Great. Thank you so much, Georgina. Okay. Next on the agenda is, before I jump into charges, let me say there are some very important people on this slide. These are all the folks, MIA and HSCRC are the two agencies that are staffing this work group. I think Riley and Janice are our lead staffers. So Riley Williams from the MIA and then Janice Lepore from the HSCRC. But we also have a tremendous amount of folks at each agency that are going to provide support and expertise all along the way. And that includes Claudine Williams, Ellen Pack, Curtis Wills, Marcella Guccione, David Cooney, Mary Quay, and Lewis Butler. So thank you in advance, team, for the work we're embarking on. Next slide. Okay. One more. So we're going to talk a little bit about the work group charges. And I think not necessarily for today, but, we've used, I think, even in our introductions, and I know when we talk about the problem, there's we all define things different ways, and I think part of our charge too is developing somewhat of a universal language about how we're thinking about denials and adverse decisions. So I just want to say that right up front, and I'll talk about that in a few places in a couple of minutes. So the work group is required to review existing state adverse decision reporting requirements for all health payers in the state. So that includes the market I regulate, our self-insured employers, Medicare, Medicare Advantage, and Medicaid, and include in its final report the number of adverse decisions compared to the total number of claims processed each year on average, the number of enrollees in each health plan offered in the state, the diagnostic and procedure information for each adverse decision, and any other data used to inform the work group's goal of reducing adverse decisions. Next slide. We're also charged with making recommendations to improve state reporting on adverse decisions, including recommendations regarding standardized definitions of medical service categories, health settings, adverse decisions, and medical necessity. A standardized method for categorizing adverse decisions and prior authorization denials, and a standardized process for reporting grievances or filing complaints and appealing adverse decisions. We're also required to develop strategies for and make recommendations to reduce the number of adverse decisions in Maryland, and develop recommendations for legislation to address the rise in adverse decisions and standardized state reporting requirements regarding adverse decisions across all payers. Next slide. Okay, actually, previous slide, sorry. Any questions about our charge and our work together?
Commissioner Grant, it's Tori. I have a quick question. I know it can feel like this charge is boiling the ocean, but I was wondering if on the first slide, when it talked about the state data on adverse decisions, is that limited to what might come up through your area of responsibility or broader? Because there's an enormous number of activities that don't necessarily get filed through MIA.
Yeah.
So I'm just trying to understand that. We can't make it too big a scope, but I think there's a lot that may be outside that purview that's equally important for Maryland.
Yeah. I think we're probably not going to solve this today, but I will say, so a couple of things. I think I'm going to talk a little bit about the data we have at the MIA today, and CRC is going to talk a little bit about what they have. I think we'll need to have a broader conversation about what might be available for Medicaid, Medicare Advantage, and then to the extent it makes sense. Also, I know the Hospital Association has done a lot of work in collecting data on this, and so I think we're going to need to talk through some of those things as well. And I've just heard some examples too from providers in their introductions, right, about what you're seeing in your practices. And so I think some of that data and supplemental data would be very helpful for us to understand. So
thank you.
Thanks. Okay, any other questions? Oh, go ahead, Dr. York.
I wonder if we could see perhaps what's done in other states in this area. If this is all important and fantastic, but it would be interesting to see if any other states have put together similar work groups and come to some similar solutions. It's a problem that everybody's working on to various levels of success. I just throw that out there and see what may have happened elsewhere.
Dan says, yes, I'd love to copy and paste from other states who do cool things. So I think that's a great idea. I'm not aware of any, though. I will say, in fact, I think I know that I got outreach from some other states wanting to know that what we had done in the commercial market on reporting. So I will. Other states definitely have cool ideas, but I do think we have some pretty good public reporting, even with gaps, that may be better than some states as well. Okay. I think this is the point where I get to turn it over to Debbie Rifkin.
Oh, you do? What's
I
next? Data. I guess we're going to talk about the data that the MIA and the HSCRC has. And Marie, I don't know
Yeah,
who wants
no,
to go over
sorry.
the MIA data. But
It's okay. I think I do need like, darn it.
I know.
I guess
Sorry
I'm stuck
about that.
talking about this. It's okay. So I think a lot of folks on this call know each December, the MIA publishes a report on the healthcare appeals and grievance law. That's required under Maryland law. We summarize statistical information that the MIA has complied for adverse decisions grievance decisions and complaints for commercial fully insured health benefit plans. So that's about a third of Maryland's commercial market. So that's individuals or employers who are purchasing health coverage. In our world, adverse decisions has a specific definition. And so I think as I heard some folks talk about the percentages of denials you're seeing, under Maryland law for fully insured coverage, adverse decisions are a bucket of denials that providers might be seeing. Adverse decisions are specifically a coverage decision denial based on medical necessity. We did clarify recently in law that it includes prior authorization denials. Grievances are then internal complaints filed by members with their insurance companies. And then once that internal process is exhausted, members can appeal to the MIA to take a look. And as Tori mentioned, it is in those cases that bubble up to us that we have a really good success rate in overturning cases. So under Maryland law, carriers have to provide to us the total number of enrolled members as the last day of the quarter being reported entitled to healthcare benefits under a health benefit plan. The next one is the total number of clean claims received for reimbursement. So we don't have that in this year's report just because there's a little bit of a delay in the law. But next year we'll have those clean claims as a denominator. I will say though, again, the percentages that folks have been sharing are much higher than the percentages I have seen for our markets. But I think that speaks to the broader issue of denials for whatever reason versus adverse decisions that are truly based on medical necessity. We look at the total number of adverse decisions issued by carrier, up to the 5 most common procedure codes, total adverse decisions issued and grievances filed, and the outcome, and the number and outcome of all other cases that resulted from an adverse decision involving the length of stay for inpatient hospitalization. Next slide. Okay, so this is again a reminder. We're only talking about in our data a third of the commercial market. And then if you include Medicaid, we're talking about 17.4% of all Marylanders under the age of 65. So our data is a specific niche. There are other things happening in the market, and we'll talk about that, but that is the caveat for what we have. We don't have data for self-insured plans. We don't have it for FEP. And we're going to publish our next report pretty shortly in the next few weeks, but we have a little bit of preliminary data that we wanted to share with you and what we saw from 23 to 24. Next slide. Okay, so this is a summary of what we see in terms of the kinds of services and adverse decisions. Overall, between 2023 and 24, we had a growth of about 2.1% in overall adverse decisions in the book of business that we take a look at. And underneath that, inpatient hospital service adverse decisions grew by about 16%, which is, I think, a meaningful growth in decisions in that benefit category. Conversely, though, we saw a significant reduction in emergency room services denials. We saw a really big jump between 23 and 24 in mental health services and adverse decisions related there. And again, it's still a relatively small percentage of the total, but definitely a significant jump. Physician services adverse decisions grew by about 3.5%. Laboratory and radiology services, which is one of the big areas for decisions, adverse decisions, dropped by close to 7%. Pharmacy services ticked up only by 2.8%, but I will just say that is the single biggest bucket of adverse decisions that we see in our data, and it's also the one that has seen sort of the most explosive growth over the past 10 years. PTOT, rehab grew by about 25.8%. Skilled nursing facility adverse decisions grew by 76.3%. Again, a relatively small portion of the total, but bigger growth. DME denials or adverse decisions went down by about 7%. Dental adverse decisions, and that's another big area that we see, went down by about 2.8%. Denials for home health services are a pretty small number, but did grow by 10%. And then we sort of have a bucket for all other medical services that we're seeing, and that sort of everything else grew by about 0.4%. So I know Louis Butler's on the phone. I don't want to put him on the spot, but let me first say that he and his team collect all this data and do a really amazing job. And Louis, I don't know if you want to add any context of what you're seeing.
Can you hear me?
Yes.
Okay. Yeah, Commissioner, you pretty much captured what the trends currently are. With regards to the adverse decisions, it did not increase to the extent. Obviously, adverse decisions over the years continue to increase, but from 2023, 2024, the increase was not as drastic as it has been in the past. But again, it's trending in that particular direction upward. But the administration is doing certain things to get the word out to individuals in the commercial market, fully insured market, to make them aware of their rights to appeal. It still amazes me to this day how individuals, consumers of insurance, don't take advantage of the internal appeals process. And I understand that a big part of that is sometimes felt like if you're a provider, maybe there's a retaliation aspect to it. So those are some of the barriers that we're seeing on our end in terms of serving as a prohibition by individuals to not take advantage of the appeals process. But as some of you have pointed out on this call, once the complaint gets to the administration, you are seeing the carrier reversal rates, and they're pretty high, relatively speaking. So the concern that I'm hearing, I definitely fully appreciate. But while adverse decisions are trending up, we want to make certain that people know that they have the opportunity to take advantage and appeal. They just don't have to accept what the carrier has issued or rendered in terms of a denial.
Thanks, Louis. Dan, did you have a question, a comment?
Well, I had a comment, Commissioner Grant, and I don't know if it's time for comments or if you just want to go through the slides or what, but I did want to have one response to what Mr. Butler just said. I mean, I think while it is notable that adverse decisions only have gone up by 2%. They're not going up a lot. I don't know that looking at the percentage of increase in adverse decisions is what we should really be focused on. I think we should be focused on total numbers. I mean, even though it only went up 2%, we still see over 111,000 Marylanders last year were impacted by adverse decisions and denials in care. And, the impact that has on, individuals and families, trying to access care is really what we should be focused on. I don't know that just the small increase in adverse decisions negates the fact that over 100,000 Marylanders are impacted by these things every year. So.
Yeah, I agree. I don't think anyone was saying that either, Dan. I think overall that trend, but agree. I think this is a large number. I will say again though, I want to make clear, in the next time we meet, we maybe can provide a little bit of context. These adverse decisions are a subset of denials. The denial rates that we see are not, again, what was cited. These represent, in many cases, less than 1% of clean claims processed by these plans. So I just want to make that clear as well. So I agree. I think this is too high. This is this means a lot of Marylanders are seeing a lot of denials. And of course, this is only a third of the commercial market, which is not even where everyone gets their coverage, right? But as a percentage of overall claims, they are small.
To that, Marie, if I could just add something real fast. To that
Yeah.
point, I think it's really would be helpful as we move forward, because I'm sure those of you who are on the work group and the public as well are going to want to give comments and provide their own views or personal experiences. It would be really helpful if you have the ability, when you're giving an example, to say whether or not it was, if you know, in the individual or small group market, was it a self-funded group, Medicare Advantage plan, or a Medicaid plan, as Marie said, because as Marie mentioned, she only has regulatory authority over a small portion of that. What can we do? And I think we have to figure out what bucket we're talking about when we start teasing this through and trying to come up with recommendations.
Absolutely. Any other questions or comments about this slide from our work group members? Go ahead, Patrick.
Yeah, I think this is just to underscore, I think the important point that you were making, Commissioner, that how we're defining adverse decisions or denials is really going to be a fundamental question in this conversation. I think when we look at sort of probably a larger swath of claims, when we look at this period of time of 2019 to fiscal 2024, we do see pretty significant percentage increases in the rate of denials. So I think the medical necessity denial increases is the largest category of denial increases. We have a 79% increase in the percentage increase of medical necessity denials over that time period. And so we also need to look at here, this is a snapshot. It's 2023 to 2024. But we do have to look at the broader trend. So I think that was a good point that was offered, and so those are really two things that I'd underscore.
Yeah, absolutely, absolutely. And I think we hear you. Wanted to provide a snapshot, but yes, trends over time are incredibly important. Go ahead, Kim.
Yeah, I also think it's important to, I guess, understand whether or not carriers are applying the accurate definition of an adverse decision when reporting this data. We often see carriers in their denial letters indicate that external appeal rights are not available to patients. Now, mind you, this is in the self-funded market, right? We see a lot of carriers say external appeal rights are not available because the decision is a coverage decision and not an adverse decision, when it's crystal clear to us that it is absolutely an adverse decision because of medical necessity or medical judgment is applied, right? And so I can't help but wonder, and I mean, it's my understanding that MIA doesn't audit this data. They may have some questions about data or see some outliers, but like the MIA, the Health Education Advocacy Unit also gets this data, and we report it on a fiscal year. And when we were doing our evaluation of it this year, there were definitely some questions that we raised with the team, with the MIA team, about some of the data that we were seeing that just, I mean, on its face appeared concerning. So do we really know whether or not the carriers are, you know, are reporting all of their adverse decisions, or you know, because I suspect a lot of them would be considered coverage decisions by the carriers inappropriately.
So we never know for sure, whether it be carriers or everyone, that the data is totally, well, let me say with a couple of exceptions, accurate and audited. Carriers do have an obligation to provide us accurate data, though, Kim, as you know, and they are subject to pretty significant penalties if we find out that there are inaccuracies. So I do think as we talk through understanding that data, or whether there are other tools to provide that, I think that's really important to talk about, and discrepancies, but as a threshold matter, we rely a little bit about what they provide us, but we have some really hefty tools to penalize them if they are providing us with bad information.
And we could probably go back and look at the definitions of adverse decision, grievance decision, and coverage decision. My recollection is that they're pretty clear, but we can always look at that as well.
I mean, and just to follow up, I mean, one example of that would be, right, early in your presentation, you said we made it clear in the statute that prior authorizations are considered adverse decisions, right? And so, I mean, and I remember thinking when that was put in the statute, I'm like, well, of course, like, I mean, why do we need to put that in the statute, right? And so, similarly, we see it in the, we're seeing it now in the GLP-1 space where a plan might have we don't cover weight loss drug provision, but then it does have clinical criteria for covering weight loss drugs. And so when they're denying coverage, they're relying on sort of we don't cover weight loss drugs. That's not an adverse decision. It's not appealable. And so these are just a couple examples that we're generally seeing. And so I truly wonder if these numbers are capturing the full universe of adverse decisions. Thanks.
Yeah, so truly capturing the full universe in the fully insured commercial market, right, Kim? Because we've already established it's not. Okay. Yep. I think all of that is fair. I think there was a clarification about prior auths being super clear that it's a part of it. We did not see a big, like I said, if we're seeing only a 2% growth, that sounds to me like it was relatively well captured. But yes. Any other questions or comments about this data?
Yeah.
Okay.
I'm sorry. I have a quick question. I appreciate Patrick's comment saying if you were to go back a few more years, how much it has actually escalated, because we've seen our denials across our own system go up almost 300% over 4 years. I mean, it's been a ridiculous ramp up, and I think we've had some offline conversations, some of the players on the screen here, about the use of AI and bots and other automation that's just accelerating the amount of denials. So we've seen a significant ramp up, and so few of the items that come through to the MIA are coming from hospitals and hospital ERs, such as maybe 10%, maybe 15%, but I think the numbers are much, much larger, and I'm not sure that we would want to start encouraging all the hospitals to send everything to the MIA that's within your purview. But I could note that we have 190,000 initial first pass denials because we have over 1 million claims across all the payers. And then in the end, it's about 40,000 final, when you get through all the appeals and whatnot. So I think the definitions I think are important in the distinguishing what falls under the purview of what agency. So, but the AI bot use is, I think, part of the contribution of what we've seen over a 4 to 5 year trend versus just a 1 year over year set of data.
So Tori, if I can just reiterate something, you did say it as well, knowing which bucket that goes in. So we know what we can, and also what category of service that was. Because maybe over time, carriers decided 5 years ago they weren't doing pre-auths or PT, and now they chose to start PT. Well, you can only see that through historical trend. And so if you or anyone else who will be providing data or information in the future can specify the category of that you're seeing the increases, that helps as well. And I just gave that as an example. PT, it could be anything. That's just because it was on the original chart showing that it's gone up, but I have no actual information that's what I just said is true. But instead of just having a generic, I know in this point we certainly are having just generic conversations, but if we can start isolating service and type of product, that would be really helpful.
Yeah, so this is a great conversation. I'm hearing a lot of things about first, I think this will not be the first time we talk about validity of data, to be clear. But I do think validity of data, data from other sources about other payers, adverse decisions versus denials for other reasons. All of these things are things we should dive into in our next meeting in more detail. Any other questions or comments?
One
and
comment I
trends
have.
over time. Sorry, trends over time as well. Go ahead, Dr. York.
Does any of this data go through CRISP? I mean, CRISP is great for all the clinical data interchange, but does any of the claims side go through there at all?
Megan, do you want to talk about that?
Sure. So certainly a lot of the clinical data goes through, especially as we think about hospital data. Some of the data that I'm seeing here, dental and DME are probably less complete. We would need to probably think through our permitted uses of the data is another kind of consideration for us. But generally, a lot of this should be there. And then I think kind of getting back to one of this group's charges is kind of those definitions. I think the more that we have clear definitions, the easier it is for us to find things in the data. And actually, I'd be curious, maybe there's some learning we can do based on these groupings, even to get started. But generally speaking, yes, but I think we have to kind of work through more specifically what that could look like.
Thanks, Megan. I know that, and Doug, I don't want to put you on the spot, but I know it last year during as part of a report, MHCC indicated that it could explore flagging denials as part of the EPCD. I don't know if that's pursued further.
We can follow up. I think that's a good flag.
Okay, great. Okay. Anything else on this slide?
Commissioner, one point on trends, and I
Yeah.
think it'd be important for analysis on trends over time, at least as long as I've been doing this. A lot of the information shared by the MIA on the reversals of adverse decisions has been related to information included from the provider on the initial claim, and it gets reversed later on due to that information either missing and being added later. I think that'd be an important analysis point in all of this to see if that trend is continuing or not. Just a point of discussion.
Yeah, so a chunk of our great success rate is the carrier takes another look for whatever reason, Zach. That might be one of them. Louis, do you have anything you want to add on that?
Yeah, Zachary, a big part of it is not only, as the commissioner pointed out, carriers having an opportunity to take another look, but in those instances, we may have to gather additional information that the carrier did not have initially. So the and the other aspect of the appeals process is that the individuals that participated in the original denial internally with the carrier, they are not the individuals that participate in the grievance. So there is a certain level of objectivity in the process. So it's a part of it is information gathering. Another part of it is individuals who did not maybe the initial review missed information that was not provided in the subsequent review. So it is a process of information gathering, and that information gathering can often result in a carrier reversal.
I
I
appreciate
think
that.
this
Thanks,
is,
Louis.
yeah, and Zach, maybe to jump in, I think this is a place where people would love to say it is the carrier's fault or the provider's fault in those spaces. I think it, as Louis is saying, it's a little murky. It's a little murky, right? There may be places where there is simply more information gathered. It's not simply that the carrier might not have had that information at the time.
No, I get
But
it.
we,
I appreciate it.
yeah,
I'm sorry.
go ahead, Dr. York.
Yeah, one thing I've noticed over a long period of time is that the amount of data that is required by carriers has increased. So there's a lot more granularity. So um, data that is used to be provided and is sufficient, a couple of years ago in the note, suddenly now is not, and they want more. And I see this also on peer-to-peer reviews. And sometimes the data will be there in the note, and then I'm talking to the peer review doctor, and we're going over the note, and it's like, well, the information's all there, and they either didn't read it or didn't get it from the carrier that then provided the peer-to-peer doc. So there's some stuff that goes on with respect to that in terms of the definition of what's available and then how that is processed through. Because on our end, we see that we are providing data, but their requirements have increased, and what they say they're receiving sometimes is not the same as what we have in our office notes.
Thanks, Dr. York. I think we're scheduled to end at 3. This is, first of all, let me just say, fabulous discussion. We're scheduled to end our time together at 3:30, and we do have a few more things to cover. So unless anyone has anything burning they want to share, I think we are going to move on. And I think lots of homework for our amazing staff teams to follow up with next meeting. Okay, next slide. Okay, here I get to turn it over to the HSCRC. Debbie, or do you or
Sure.
someone from the team
Well,
want to talk to
yeah.
this?
So thank God you talk about policy experts or subject matter experts. So I've got Claudine Williams on, who can generally talk to what we have, because it is different than what's collected by or what's given to the MIA for you to collect. And so as you all look at this and you hear Claudine talk about it, we may have to dig a little bit in different ways to try to get data that's helpful, because it's not an apples to apples comparison.
Yeah.
Claudine, do you want to jump in and just go through the different points very quickly?
Yes, good afternoon, everybody. Thank you for having us on. So here at the HSCRC, we collect information on denied cases. So we collect the total number of cases with billed charges that was written off as denied, and then the total denied charges for those cases. And we receive that on a quarterly basis from hospitals. The data can also be further aggregated by the payer type. So whether it's a Medicaid, a Medicare, commercial, et cetera, the individual health plan payer, so Care First, Humana, United Healthcare, the patient category, whether it was an inpatient claim, outpatient, or ED, and then the reason for denial. So that could be medical necessity, EMTALA, what have you. So this data is not at a claim level, so we can't go back and directly link it to a case mix record where we can see the additional clinical and payment information. So that information is not available, and we do not audit it or validate the data that comes in because it's so aggregated. We're unable to really compare it to anything else. So unfortunately, I didn't have time to pull together some data from our data sets, but I was able to have one of my colleagues at least pull the total amount of denied charges for fiscal year 25. And so it was about $517 million. About 22% of that came from commercial insurance, and of that commercial bucket, About 34% of those commercial cases came from Care First, and we have 19% coming from United Healthcare. And then the next large bucket of denials was in the Medicaid MCOs. That was about 36% of that $517 million. And then Medicare Advantage came in around 16% with $84 million. So for the next meeting, we could probably dig a little deeper and look at it by by patient category and denial reason. And we also have this data going back to fiscal 19, so we can look at it over time and over a longer period of time. At the HSCRC, we are working with hospitals as well as with MHA to develop a claim level patient denial report. So we can actually link these final denials to our case mix data that contains the clinical information and be able to kind of dig underneath the hood to see what kind of services are being denied and by whom. So that work is ongoing. We hope to be able to start collecting data in calendar year 26. So that is our goal. And so we will update this group as that moves along.
Thanks,
Any
Claudine.
questions?
Oh, go ahead, Deb. Sorry.
No, I was just going to say thank you.
Ms.
Go
Marie,
ahead,
this is
Dr.
Dr. Singh. Yeah. Sorry, I had a comment and a good question raised, Ms. Williams, about the data collection. I wanted to add from the outpatient services, the denials also come from like multiple bills are submitted, multiple services, and only one of them is paid and rest are denied. And I think that's important to understand. It makes a significant volume. Like I see a patient, I bill a follow-up E&M code and a couple of codes, and maybe I did a smoking cessation and I bill that. And only smoking cessation is paid, everything is denied. And it's very difficult to get back, which is a different story. But I think that should be part of the data very importantly in outpatient settings, since we are using multiple codes now. Also, sometimes you bill insurance and they deny it and saying that patient has another insurance. And I think that also is important. How is that counted as a denial or not? Because there's a kind of a bouncing the responsibilities to different insurances, which we are not aware of. And lastly, the insurance clawback. So it's 3 months later, 6 months later, they send you, oh, we are taking this back. There was another insurance or whatever denied. And I think all those are important metrics as we define what are denials, because all those are used as different means to claw back the money, and that's what we are talking about. Thank you.
I want to highlight Kim Camerata had a question in the chat about Claudine, the scope of your data. There are hospital charges. I don't know, Kim, if you wanted to ask that.
Yeah, I just wanted to clarify, this is hospital data, not other provider data, right?
No, yes, this is hospital data.
Okay.
Hospitals are reporting this information, correct?
Right. I just wanted to.
Yep.
Thanks.
But all payers. I think
But
this
all
one
payers.
maybe one of the few
Agreed.
places where we have everyone.
Yeah,
Yes.
I just want to make sure that there was not some other reason, the HSCRC's data collection and analysis duties have expanded, and I didn't know if perhaps this was an area where it expanded beyond collection of hospital.
No,
data.
we've got enough to do, Kim.
Yes.
We're good.
Yeah, I just want to clarify and confirm. Thank you.
Go creep. We're good.
Patrick.
Yeah, I just wanted to affirm Dr. Singh's point. We can have a claim that has partial denials, and it's really important to understand that as we're looking at the data. I think another issue where we see a big problem is in the emergency setting. And I know that we talked a little bit about that earlier, but we can have a scenario where you have significant downcoding because of claims review practices that might be just looking at procedural or a diagnosis codes, but not actually at the clinical information that's documented, which is a little bit of a different challenge, that was described earlier. But we need to make sure that we're having a full line of sight on the type of review practices that are being implemented, particularly with AI. So if we're seeing a high volume of denials, for example, in the emergency department because of this type of practice, that can be really disruptive. And so I think we're going to see that that's going to feature pretty significantly in this inquiry when we're looking at the full scope of denials. But just wanted to offer that.
Yeah, Patrick, I'm very interested, not now, but when we get to this, to understand how these denials are happening with EMTALA. I can't wrap my head around it, but so I'd love to learn and obviously hear from the carriers as well. What's the rationale?
So I can add to that a little bit. We have patients coming in. Yeah, obviously they are not able to self-diagnose. They feel like they need to go to ER based on whatever they're feeling. And due to prudent layperson standards, they should be covered. And the insurances should be paying based on symptoms, not final diagnosis. And one of the things that we've noticed at university is we have been taking a number of our cases directly to the IRO after we have exhausted all the appeal efforts. So that's the independent review organization. And we're very successful there. And the number one verdict that comes out from the ED is the patient's clinical presentation meets the Maryland prudent layperson standard for an emergency medical condition. And if you look at our ED denials just for the last 6-month period of January through June, 23.5% of them were overturned on the first level. So that just shows you that they should not be denying this stuff coming in the emergency department.
Well, Heather, again, when we get to because we'll want to hear that information again, if you can break that down for Medicare Advantage, MCO, Medicaid, commercial carrier, that'd be fantastic.
Okay, but yeah, so hopefully that's helpful. That's some of the places that we'd like to see change.
Heather, Doug.
Thanks. Just in response on the data quality and the all-payer claims database. So we don't currently collect information about denials or prior authorization. However, this year we're looking to add basically a flag as part of the APCD if one of the claims is subject to prior authorization. Right now, we only collect information on covered services, and so we'd have to look more at denials, but it's not something that we currently collect.
Got it. Thank you. Okay. I'm gonna, Jai.
Yeah, I'm just curious, what we're going to do to establish definitions here, because I know you've talked a lot about it, Commissioner, in terms of the adverse decisions, but now we're talking about cases, and I'm not sure how cases translates to adverse decisions. And I'm not sure how cases are translating to denials. Are we talking about claim denials? I think Ms. Williams said it wasn't explicitly claim denials. So, it is going to be critically important to establish definitions here. And when we're talking about, I think it's the first bullet here, the total number of cases with billed charges written off, is that any portion of that case that might have like an administrative day or something written off where we're paying a partial on that? Or is it 100% the whole entire case is not paid by a payer?
It includes partial denials. So this data set includes partials, yes.
Okay. And then in terms of the denials, would it also include things for eligibility, for example?
Meaning,
if a person wasn't eligible on a data service?
Yes, it would include those as well, yes.
Okay, and the last one is, I guess, not covered benefits. If a benefit's not covered, would that also be in the bucket?
That would also be reported to us, correct.
All right, well, whatever we can do to establish the definitions, I think it's going to be helpful.
Yep.
Okay, that's great. Anything else? Because now, again, see, we can't do a report by December 1. So maybe I'll turn it over to Debbie then.
Yeah, so one of the things I just wanted, Marie and I wanted to talk about is that the law itself was ambitious, that we would be able to have a report that would be available back to the legislature and finalized as of December 1 of this year. As you know, it's our first meeting. We just got everybody appointed. So, and obviously based on all the information you've already started giving us today, we're going to need more meetings for us to really be able to allow sufficient time to collect data, analyze and report on that data, get public comment from whoever wants to participate, as well as get information from all of you, and then make recommendations. So knowing how much work we have ahead of us, we clearly will need some additional time. And so we plan to write a letter to the legislature requesting that we can have additional time and extend our report to January of 27, which hopefully will give us enough time to really dig in and figure all this out. So having said that, obviously, if anyone has a concern or a comment they want to make about us extending our time, this would be your opportunity, but we think it would be prudent for us to do that.
Delegate Kerr, go ahead.
Yeah, thanks. Deb, this would require a legislative change to extend our sunset, right?
Yes.
Um,
I believe so. I mean, it was in the law, it was in the statute, so I think that would be,
is that
I don't know, Marie, as a former staffer, can they make that determination to allow us to continue, or does it have to be in statute?
My guess is it's statute or
Statute?
legislation.
Yeah.
Is that the only change you think we make? Because we can go ahead and get that change drafted.
That's the only one we had come up with at this time.
Yeah, or we can wait until our next meeting or talk offline about it, but we can get that process started if we know we're going to ask for a sunset extension.
That would be wonderful. Thank you very much for your help on that.
You're welcome.
Thanks,
anyone else?
Delegate Kerr.
Okay, looks like we'll be working together for another year.
Oh, Patrick, go ahead.
So it is also the case that sometimes these extensions can be granted with an inquiry to the chairs of the statutory committees that
Okay.
have jurisdiction over the subject matter areas. So that might be something that you want to consider that may not require legislation, just to continue the work of this group without a statutory change.
Spoken as another true good staffer. Thank you, Patrick.
I know. Patrick and I can offer the finer points about this offline. Because I think in theory we can do that. In practice, sometimes it's better to have it formalized under law. Okay, well, as long as folks are comfortable with that extension request under whatever form that it takes, that would be, is anyone uncomfortable with that?
I'm not uncomfortable with it, but should it be another full year? Like, does it have to sync up with the end of a calendar year versus it could be like I mean, if we were committed and intense about our work over a 6-month period, could we get to a set of recommendations that could then roll into the General Assembly if there's legislative action needed versus you miss 2 cycles potentially of the General Assembly? I mean, I'm just worried we might miss 2 cycles if we extend a full year.
Well, I think we still would have time because session wouldn't start, in the very beginning. So we would have the opportunity to work on legislation if that were appropriate. We wouldn't necessarily have to miss 2 sessions. And I do think, and Marie, please give your thoughts as well. There's a lot of information that this report is asking for us to make recommendations on. It's going to take some time, especially with the legislative session coming up. And many of us and you all are going to be turning our attention to legislative matters for 3 months. It's difficult to get everybody together, especially the fact that we've got legislators on this work group as well. So we probably think to crunch the numbers, develop a report, we need the full time.
Yeah. Maybe just to add to the, because I hear you, Tori, I hear a real desire to work on this and get this done for next session. I think that is definitely from an agency staffing perspective, our goal too. I think asking for to December or January gives us just a little bit of breathing room in case things go long. I will say for folks who haven't worked on these things before, when we say a report is due January 1, that means you all are signing off on it before December 1 because it has to go through several layers of review before it can be published. So.
Gotcha. So we may essentially during session, the 90 days be, not that we would want to declare it, but we might be effectively on a hiatus.
My hope is that we can get at least one meeting during session, actually. But yes, it will be, I think, a little bit harder to get folks together.
Thank you.
Okay, any other questions? Concerns with an extension? I think we will share the letter we plan to send around with the work group before sending it, just for transparency's sake. Okay. We had time. Sorry. Oh, I'm talking about this. So again, more information to come here. The legislation requires us to elect a chair of the work group. We're gonna set up a process where folks who are interested in chairing can apply, and so more information to come on that. We will get that out via email to you all. Next slide. Okay. So we actually have a number of people signed up for public comment, so I do want to open it up for questions or comments from our work group members. Anything else you would like the staff from MIA and HSCRC to look into before our next meeting? You can go ahead, Tori. And you can also, this is not your last bite at the apple of it. You can always follow up in writing, but we do have a handful of folks who wanted to speak as well. Go ahead, Tori.
Thank you. I appreciate the energy and enthusiasm that everyone's bringing to the table, and also the enormity of the task that we have in front of us. We talked about greater transparency. I wonder if part of our task should be recommending some set of standardized set of like the rules of the road, because there's so much variability from payer to payer, product to product. You know, you're trying to navigate what are the rules, and it's very inconsistent. I would like us to probe a little bit on the use of AI. It's with us, it's here, we all need to figure out how to use it, but is it being used in the best interest of Marylanders? The EMTALA issue we touched on, and we can provide more data on that, but there's an enormous number of ER denials, in particular from the Medicaid MCOs. This issue of definitions, if we're going to try to get data around something, it's sort of like chicken or the egg. Do you decide the definitions, or do you start collecting a bunch of data? But I'm all for the data. One issue that we didn't really touch on that I'm wondering if it could be within the scope is maybe even assessing, you know, what should or shouldn't require an authorization. As the span of what requires an authorization just gets bigger and bigger and bigger, it really confounds clinical decision-making and judgment of the providers, the docs. So I just think that keeps getting wider and wider and wider, and it's just more bureaucracy, administrative burden, and red tape. And then I don't know if we have anyone on the group from post-acute, but one of it, more than an anecdote, is when hospitals are having trouble placing patients into post-acute care, whether that's home care or SNFs or the like, denials or delays and authorizations for that level of care. And by the way, the patient doesn't need to be in the hospital any longer, so you're not getting into the level of care you need, and we're going to deny you for the care that you're continuing to get in the hospital. So it's like a bit of a double whammy, but I don't know if we have anyone in the post-acute world that can help craft recommendations as well, because there are significant delays in getting patients moved to post-acute services. That's on my short list, but I'll stop there.
Great. Thank you, Tori. Dr. York, and then Patrick.
Yes, thank you. Yeah, to get at the issue of definition of an AI or AI product, particularly that is within the software that already exists on the insurance side for dealing with claims, is important. I'm on the informatics caucus of the AMA. We're dealing with and having some seminars on trying to get a handle on these issues in terms of health policy and figuring out where the bad guys are in this issue. I testified on Senator Clarence Lamb's bill last year, which would have established a statute for regulating AI products in any type of healthcare, whether it be insurance or on the clinical side. It failed in partly because of the issue of trying to define what an AI product is. Is it a de novo product? And typically it's within something else. So that's something that we may need to get into the weeds on.
Yeah, thank you. And we can follow up. So although that bill didn't pass, there were a couple of pieces of legislation, or at least one that did pass. And I don't know that we have the data today, but we are going to be getting more data on the use of AI in the adverse decision process in that portion of the market that I regulate. Patrick, go ahead.
Yeah, just recognizing the challenge of boiling the ocean. I do want to affirm the point that Tori Bayless made about the challenge of post-acute placements and the difficulty of getting authorizations. If that can really be within the charge of what we're looking for in this conversation, I think that could really be important. We really do want to make progress with emergency department throughput and access to services, and that's a key piece of it. And I think if we're going to focus on the things that really have a substantial impact on patient care and access and operations within our hospitals, that's a good place to focus. And then again, the emergency department denials. I think that's a great opportunity for focus. So just want to underscore those 2 points.
Thanks, Patrick. Any other of our work group members before we move to public comment?
Just very quickly, Dr. Singh here. I think I would want to add what has been said for denials, for the testing denials or for the payment denials in any fashion or way. It must be clarified. I know right now it is clearly the reason and the resolution for it, both. I think it is not done enough and it's not fast enough to resolve those barriers which may be there. And I think it's very important part of whatever we come up with, that it's an integral part of a very fast resolution in real time. And it should be easy enough to be done. Very often it is so convoluted and complicated that it is easier to give up and move to the alternatives. Thank you.
Thanks, Dr. Singh. Any other work group members? All right. I have Amy Barley as signing up for public comment from the Health Exchange. Amy, are you with us?
Here, can you hear me?
Yes.
Hi. Hello, everyone. So first and foremost, I just want to thank you for the opportunity to share my perspective. So my name is Amy Barley, and I'm a resident of Anne Arundel County. And as Marie stated, I'm currently working for the Maryland Health Benefit Exchange as a digital marketing professional. And I also happen to be type 1 diabetic. And I've been living with this disease now for over 30 years. And throughout all of this time, I have navigated countless insurance approvals and prior authorizations for the tools and the medications that keep me alive, such as insulin and glucose sensors, pump supplies, specialist visits for endo, eyes, heart, feet, you name it. There's a whole list. So I speak today on behalf of everyone who lives with a chronic life-sustaining disability, who continually face repeated adverse decisions. For most of my life, these processes were almost always burdensome, but generally manageable. However, in the past few years, I've seen a deeply concerning shift where denials and delays have become far more frequent, and even for treatments that have been medically necessary and stable for decades. And I now find myself spending hours, sometimes weeks, appealing decisions for the exact same prescriptions and devices that I've been using safely for years. There's actually a running joke in my type 1 diabetes community. If you think that the holidays are extremely stressful, then try living with a chronic condition and facing the month of January when all of the prior authorizations need renewals. And let me just tell you, it is not for the weak. These denials don't just create paperwork, they aren't just administrative delays, they're medical risks and, dare I say, medical malpractice. Every delay in waiting for approval on insulin delivery or diabetic supplies will directly impact my blood sugar control and my long-term health. And on top of all of this, the emotional and mental health toll is also significant. Living with a chronic condition is already a full-time job. It is extremely stressful. And these administrative barriers make it feel like we're being punished for simply trying to manage our condition responsibly. So I really urge this work group and policymakers to examine these practices through the lens of the Americans with Disabilities Act, because diabetes is considered a disability under the ADA, and many others who live with chronic life-sustaining disabilities are facing repeated adverse decisions as well. We all know that the Affordable Care Act was designed to end discrimination against people with pre-existing conditions, many of which are disabilities under federal law. So when insurers create repeated delays or denials for medically necessary care, they're effectively recreating those same inequities that the ACA sought to eliminate. And when a system consistently creates these extra barriers for a specific group, like people with disabilities, who are now facing heavier burdens from prior authorizations, that is, in my opinion, a form of systemic discrimination. And I say this because I want us all to remember that disability is part of the collective human experience, because a majority of disabilities are acquired through age, accident, or illness. So that means everyone here today who doesn't currently have a disability is just temporarily non-disabled. It's an identity that anyone can enter at any time. So, excuse me, I thank you for listening and working toward a system that truly supports patient health, equity, autonomy, and consistent evidence-based care. And I would be very happy to participate in this work group to provide input through the patient and consumer lens. And I'd like to end my comment with this question. Can we somehow update state laws and policies in a way that clearly considers the needs of people living with disabilities, knowing that they're often the most disproportionately affected and the most at risk when prior authorizations are used unfairly or too often? Because while not every single pre-existing condition is legally considered a disability, there's a very large share that would qualify because they absolutely require ongoing treatment or significantly affect daily life. So thank you and happy National Diabetes Awareness Month.
Thank you so much, Amy, and thank you for speaking so clearly to why we're here and what this is all about at the end of the day. Just thank you. Thank you. We're at 3:29. I know there's one other person here that wanted to speak. So Lynette, if you're here, would love for you to say a few words. If you're not able to cover everything you want to, we can invite you back for next time. So this isn't your only bite at the apple. But thank you. Welcome.
Well, thank you. I'll keep this short. I don't know, because I read that it's an adverse group, but this is my 1 cent to it. You know how insurance company and network provider, they have this negotiation in price. My thing is, suddenly they will say, well, we will drop this network provider in the middle of the year. Like, for example, me, I'm using Johns Hopkins, and then all of a sudden I have continuous care, and then Johns Hopkins says, well, we don't take United Healthcare anymore. This United Healthcare, I signed up through the federal government because my husband is with the federal government. So that's, although it's, for me, that's a denial because they dropped Johns Hopkins. So what am I going to do? And then I have to pay out of pocket, and United Healthcare has made the customary fee lower in the middle of the year, lower, so they would pay less than I would pay out more, So I don't know if this is part of the work group. So that's my one cent. I have several, but that's one that's more urgent. Thank you. Thank you for having me.
Thank you so much, Lynette. And I don't know if Kim wants to weigh in here at all. I know, first of all, at the MIA, we're very concerned about making sure United members have continuity of care to the full extent of the law and beyond, and are meeting our network adequacy standards. So we don't regulate the federal employee plan, unfortunately, but this is a really hot topic, I know, not just for you, but for a lot of Marylanders. Kim, I don't know if you had anything you wanted to add.
Yeah, only to the extent that we can certainly assist consumers that are federal employees should their carriers be denying coverage improperly, including the continuity of care requirements afforded by the No Surprises Act. So if you believe that you might qualify for continuity of care, meaning you can continue to receive care for 90 days from when the carrier and the provider sort of broke ranks, we can sort of help you. We can help you with that. We can help you analyze that and ensure that you have that continuity of care. And you can do that by filing a complaint with the Maryland Attorney General's Health Education Advocacy Unit. And I can drop that link in the chat for you.
Thank you.
All right, well, thank you all. I think we're a little bit over time, lots to follow up on, lots of great discussion. We'll keep you updated on a chair process as well as the extension request, and look forward to working closely with all of you on these important topics. So thank you all. Thanks for the great discussion. Debbie.
Thanks, everybody. We'll be talking soon. Just get everybody back.